Hi, welcome to our update on Omicron and the latest information on aspirin from the U.S. Preventive Services Task Force. I welcome you to this discussion, and I know the two topics are not related, but lots in the news this week about Omicron, so I thought we should catch up about that. But there's a lot more information that I'd like all of you to know regarding aspirin because we think it's benign, but it's not. And gone are the days of take two aspirin and call me in the morning. So, a little bit about the history of aspirin. It's been around for thousands of years. It was actually discovered as an herbal medication from the willow bark as an anti inflammatory from the year 1500 BC to 3000. And in Greece, Hippocrates administered willow leaf tea, thinking to help with the pain of childbirth. Subsequently, it wasn't until the 1700s where there was some more research being done that said the dried powder in the bark could cure fever. And then a scientist in the 1800s um, extracted the active ingredient, and it's called salicin, and he named it salicin. Later, they found it was salicylic acid as the chemical structure, and it wasn't until 1897 when a scientist working at the pharmaceutical company Bayer found that by adding a little acetyl group moiety, it reduces its irritant properties, and Bayer patented the salicylic acid. It entered lots of clinical trials, and it was in the uh, Guinness Book of World Records by 1950 as the most frequently sold painkiller. It wasn't until the 1990s where large preventive health studies were performed that showed there was some cardiovascular benefits to the use of aspirin and maybe even some cancer benefits. And subsequently, it was used quite a bit as not only in the treatment of something like strokes or heart attacks, but then it our thought process was is if you had the risk factor for strokes or heart attacks, maybe people should just take it as prevention. And that's where our conversation will lead today. So how does aspirin work? Aspirin blocks something called COX-1 and COX-2. And we have these things called phospholipids that turn into prostaglandins in our body. And those prostaglandins can cause our blood to get clotted and they increase our smooth muscle and make our um, vasculature narrow. They are proatherogenic. There's also something called prostacyclin that can enhance our gut protection and regulates kidney blood flow. However, when we block that pathway by something called aspirin, then we get thinner blood and we've got maybe a little bit more um, kidney issues, or we lose our gut protection. So it's important to know how aspirin works in this setting to know how some of the side effects can be. So let's talk a little bit about salicylate toxicity. It's surprising. In 1918, during that pandemic, there was a lot of salicylate toxicity, and that is overdose of aspirin products because of fever and muscle aches. But you'll be surprised to know that salicylates are found in a lot of common things that we don't even think about, like Aspirin or Pepto-Bismol. If you can see here, it's bismuth salicylate, Excedrin, as well as oil of wintergreen. And even if you get natural mints, and if you're already taking an aspirin a day and then you use any of these items, you will actually increase your risk of toxicity, especially if you have underlying kidney or liver disease. So, early signs of having too much aspirin on board will give you ear ringing or tinnitus, vertigo, nausea, vomiting, and rapid breathing. If you have intoxication by aspirin, like a suicide attempt, uh, you can get fever, sweating, listlessness, hallucinations, seizures, coma. You're in the ICU by this time. Um, so let's talk about a way that you can inadvertently increase your levels in the bloodstream of aspirin. Say you're taking a low dose aspirin, you hurt your knee, you apply topical aspirin cream, apply a heating pad on top of that, drink a cup of mint tea or ginger tea, and suddenly the heat has enhanced absorption of the aspirin through your skin and disperses it over a greater area. It gets into your bloodstream. The ginger tea or mint tea enhances further absorption of your regular aspirin that you've taken, and you can get a higher plasma level of salicylates. So here is an image of the mechanism of just dosing and how aspirin will enter your system, and it depends on how much protein you have in your body and how it can go through the liver and the kidneys. And so when you ask me, is aspirin okay to take, or is Motrin okay to take, or some other medication, this is what I am looking at with all of your other medicines on your med list, and I'm looking at how they can interact, what your liver function is, what your kidney function is, and what you can tolerate. And so I just wanted you to get an image of what I see visually inside of my head when you ask me a question. And these are the things that I think about in terms of your safety. Let's talk about some of the drug-drug interactions. If ethanol or alcohol, when you're consuming alcohol, it increases your risk for GI bleeding. As we alluded to before, aspirin can thin the lining in our GI tract and increase our risk for bleeding. It's also a blood thinner and makes our platelets less clumpy, so it increases our risk for bleeding. And we used to see a lot of that when people were told to take higher doses for prevention or treatment. Anti-inflammatory painkillers plus aspirin, like diclofenac, ibuprofen, naproxen, combined with aspirin, they can increase your risk for stomach bleeding. SSRIs or antidepressants also can increase the circulating levels of aspirin in your system and increase the risk for bleeding. Of course, being on a blood thinner and then adding aspirin to it um, sometimes is used commonly if you have a cardiac stent, but it does increase your risk for GI bleeds. So this is something that we consider. And then in certain other diseases, if you're on a drug such as methotrexate or other cancer treatments, sometimes aspirin can make that drug harder to eliminate and increase certain other levels of chemotherapy that then make that toxic to your system. Of course, we learned early on that aspirin given to children during viral infections cause something called a Rise syndrome, so aspirin should be avoided in children. Now let's talk a little bit about how aspirin is used therapeutically and somewhat preventively. This is a slide picture image from the Aspirin Foundation. It's an international committee with some really learned scientists from all over the world. And they kind of keep up with the global literature on aspirin clinical trials and guidelines. And from that, we know that we can do some prevention, but there are other indications for aspirin as giant cell arteritis, rheumatoid arthritis, lupus, pericarditis, which is an inflammation of the heart, some retinal disorders, and Kawasaki's disease. So let's go back to the slide previously. doesn't look like I can. Um, it has been used for cancer prevention. We use aspirin for strokes. We use it for cardiovascular disease. And aspirin is also used in pregnancy. So let's look at aspirin and cardiovascular disease. First, we need to talk about what's the difference between primary prevention and secondary prevention. Primary prevention means that if you take something, you won't get that disease. Secondary prevention means if you've already had that disease, then you take something to prevent a recurrence. So in primary prevention, this is where our data has changed and the thoughts are changing. Is that before we used to say that low dose aspirin may be able to help prevent heart attacks and strokes in everybody over a certain age. Now, modeling studies as well as some preliminary studies has shown that the timing of when you start your primary prevention matters. That people who are younger between the ages of 40 and 60 benefit more than people over age 70. So, and especially you have to look at that person's risk for bleeding. Low dose aspirin should not be administered on a routine basis for primary prevention in people who are without risk factors and over age 70. And it should not be administered among adults who are at any increased risk for bleeding. Sorry about that small print there. For secondary prevention, we still strongly recommend aspirin for certain groups of people. Those who have had a cardiac event, a heart attack, anybody with angina or chest pain due to blockages in their coronary arteries. Atrial fibrillation in some people, although other anticoagulants are usually prescribed. If you've had a heart attack, a recent heart attack, or a stent implantation, for a stroke, or if you have peripheral artery disease, although other agents are favored. What hit the news in September was a modeling study done by the U.S. Preventive Services Task Force. Based on data that 720,000 Americans will experience their first heart attack every year and 610,000 Americans their first stroke, Kaiser Permanente Evidence-Based Practice Center performed a kind of a simulation modeling study looking at some recent data that was published as well as some future risks benefits of aspirin as prevention. And they found that daily low dose aspirin does reduce your risk of non-fatal MI, but the largest impacts were in males and females aged between 40 to 59 and who had a greater than 10% risk of cardiovascular disease. And that means your family history, high blood pressure, or high cholesterol, or you're a smoker, plus minus diabetes. It was interesting also in their modeling analysis that if you stopped aspirin at 5-year intervals between ages 65 and 85, there was some benefit. However, for men and women aged 70 to 89, so it's kind of fuzzy here, the lifetime net benefits were negative in terms of life years saved and risk for bleeding. And so that's why they published a recommendation in September saying to folks, you don't need to take aspirin if you're over age 70. But data still, and firm recommendations are still pending. The American Heart Association and American College of Cardiology said that aspirin should be avoided in the following groups: people with an increased risk of bleeding, like a history of gastrointestinal bleeding or from other sites, age greater than 70, or if you have a low platelet count or a bleeding disorder, if you have chronic kidney disease. And they also said don't use it if you are using NSAIDs, which are the nonsteroidal anti-inflammatories, and anticoagulants. It's definitely well established that we do need it for folks who have known coronary disease or stroke, but not for routine prevention. So what if you have diabetes? Isn't that a big risk factors. So, the American Diabetes Association states that men and women aged 50 years or older with diabetes and an additional risk factor, such as family history, high blood pressure, high cholesterol, smoking, kidney disease, who are not at an increased risk of bleeding and have already shown that they're of age greater than 70, they have underlying anemia, renal disease, are most likely to benefit from a low dose of aspirin for prevention. But this is where it gets interesting. They suggest that maybe you might want a little bit more proof before you put somebody on aspirin. Like, do they show evidence that they're forming plaque? And do some like a carotid ultrasound or something non-invasive to risk stratify. So ultimately, the recommendation is talk to your doctor. Now, what about aspirin and cancer prevention? The UK group that looks at data and guidelines called NICE, they recommend aspirin for 2 years if you have a genetic marker for something called Lynch syndrome, which is a high risk for colon cancer, but no benefit if you start um, any earlier. And people are rethinking this, whether a one size fits all for prevention is necessary. Like, what are some other risk factors for colon cancer, and how can we nuance that and find who would benefit? Andrew T. Chan is a gastroenterologist at Harvard who is also on that Aspirin Foundation board and states, and I think I agree with them, one size fits all approach is a failure. You don't give it to everybody to prevent colon cancer. More data is pending. Now, if we look at aspirin and how it helps prevent colon cancer, we really don't have all the answers here yet, but here is one theory that we showed you aspirin blocking the COX and making the blood thinner, and platelets are then not going to be activated, and you've got some thinning of the blood and some anti-inflammatory pathway. So you've blocked some inflammation. We do know that inflammation then triggers changes in our cells that may trigger cancer mutations. So here's normal cells, here's a polyp that's forming, and here's cancer and then metastasis. And we think some of this pathway may be blocked by just giving aspirin or some other antiplatelet agent. More to follow as more research is being done. You can read a ton of different articles, and there's all kinds of little mediators in here that may be blocked. But we need to, if we knew how cancer was formed, we could prevent it. But there is some benefit to taking aspirin in some people as cancer prevention for colon cancer. What about aspirin and pregnancy? For the USA guidelines, preeclampsia, which is high blood pressure in pregnancy, the U.S. Preventative Services Task Force recommends low-dose aspirin after 12 weeks of gestation as a preventive medication in women at high risk of preeclampsia. And that's the only indication for pregnant women. What about aspirin to prevent stroke? Now, that one does require what's called shared decision making with your healthcare provider to assess the risk and benefits that you have personally for stroke. Ultimately, the advice is do not start aspirin on your own without talking to your provider or doctor. So, in conclusion for this section, as primary prevention, to prevent a heart attack, take one aspirin a day. Hold it in your hand. Take it out for a jog. Take it to the gym, and then take it for a bike ride. It's probably better that you exercise and eat right than swallow an aspirin to prevent a heart attack or stroke. With that, I'm going to segue to the Omicron update, which I know you all have been waiting patiently for. So Omicron is something that everybody is in the news a lot. In October, I pulled this article from Nature showing that vaccine makers were already bracing themselves for a variant worse than Delta. At that time, they had no inkling that Omicron or any variant like that was on the horizon, but they were preparing themselves. Just a few days ago, the first Omicron variant case was identified in San Diego. Countries all around Europe are seeing an increase in the spread of Omicron, and what our experience here in a few weeks or a month is going to be what Europe is experiencing now. And so we should look to them to decide what our future will look like, especially the UK and other areas where Delta was predominant. Right now, Omicron is taking over some of the Delta, and in some areas, as much as 25% of circulating COVID is Omicron. There are some great websites if you feel like you want to track Omicron spread, and you can see it's now quite global. We just don't have any reporting from here to document anything. But you can see that as of the 9th of December, the UK had confirmed 817 cases, the US 71, but we likely have a lot more cases on the rise. If you look at our earlier part of this year from spring to summer, we were B117, which was the UK variant, followed by Delta variant, and Delta quickly took over the B117. Now, it is anticipated a similar trajectory will occur with Omicron, and as of the 4th of December, we're just leaving a small little line there for a few cases of the Omicron. So let's talk about variants and how they form, and what is probably the biggest question on your minds is, will our vaccine hold? Well, if you recall from our prior conversations, the coronavirus has these spike proteins which form a corona or a halo around it. Of the spike protein, we have a binding domain, which is where the Moderna vaccine creates the antibody that we can help target. And the Pfizer vaccine creates an antibody against the entire spike protein. Now, when we saw earlier circulating variants, we still had enough protection to fend those variants off. And it was anticipated by this modeling study that was published in Science magazine back in June of this year, or maybe August of this year, that it would take about 20 changes to the spike protein for it to escape our current antibody response completely. So here is an image of the Delta variant with all of its 18 mutations. Here is Omicron with 43. It is anticipated that we can be triple vaccinated and still get Omicron. However, there is some hope that we won't get as sick as Delta or as if we were unvaccinated. There is more studies to be performed looking at exactly what percent neutralization the antibodies that we have currently in our system to triple doses will provide. But we should look at Israel, which is the country that is triple vaccinated, and look to them to see what their caseloads are doing. What do we know so far? This was from a CDC conference call last weekend. And we know that the variant has infected fully vaccinated people. We don't know if they were boosted or not. People who have recovered from the Delta variant do get the Omicron variant infection. We just don't know enough about signs of symptoms or severity yet. South Africa was heroic in alerting the world, but we're still waiting for more information on their hospitalizations, ICU admissions, or any deaths, signaling that this variant is more toxic to us. But this is still very early. It does, some news reports are showing that in Africa and South Africa, the hospitalizations are on the rise. Many anecdotal reports suggest that the illness is mild and confined to young adults, children, and travelers, but those are folks who are out and about. We already talked about some of the mutation changes, but we don't know anything about. We do anticipate that it's not going that our vaccines aren't going to be perfect. We do also know that compared to the original wild type COVID from a year and a half ago, the Delta variant was 2 times as infectious and transmissible. Omicron is likely 4 times more transmissible based on our current data. And what's on the radar is this story here in November of 2 travelers arriving from South Africa, and but or and one is a South African native, another was Canadian. And in Hong Kong, they are have excellent quarantine. So for everyone who enters the country, they're quarantined for a certain period of time and regularly tested. These folks had tested negative prior to arrival, and they were confined in their rooms, and there is video surveillance. These folks are delivered food, and they're supposed to wear protection, and so are the people delivering. These 2 gentlemen there, or people, were across the hall from each other. They never saw each other, and they were all negative within 72 hours before arrival, and one was turned positive on the 13th, no symptoms. The other one, and they arrived on November 11th and 10th, so um, one day apart. And then another one popped positive with mild symptoms on the 17th. And the viral genomes were very similar. So, more to follow in terms of what was the HVAC system and pattern of flow of air to see if there was some kind of cross ventilation issues that caused this. If there is a slide you want to take a screenshot of, this is it. This is something that I usually put together monthly for kind of a quick summary update to my CalMat team. And I presented some of this information to our meeting this week. The Omicron variant has been dubbed B.1.1529. It is estimated based on sewage analysis in Northern California that 1 to 2 out of 100,000 people in our state likely have Omicron infection, but we don't have definite confirmation yet. The Delta variant is circulating quite wildly in California and comprises 99% of all cases. And it's dubbed B.1.1617, and there are over 50 subtypes. So we still need to be concerned about the Delta variant. We know that our antibody response after 2 shots wanes after 6 months, so boosting does protect us from the Delta variant. So it is still highly encouraged to get yourself boosted. I know most of you already are. But if in the next 4 to 6 weeks, the Omicron variant takes over as it's doing in Europe, and folks are at high risk, those who are, on oxygen or who on a regular non-pandemic time would be at high risk for any influenza. I do have some hope that some treatments that exist now will fight Omicron. It's awkward to practice medicine from press releases, but on December 7th, as press release was submitted that showed that sotrivimab, a monoclonal antibody, retained activity against the full combination of mutations in Omicron. So I have hope that if Omicron became the dominant strain, we do have something we could provide. However, we still right now are primarily using these monoclonal antibodies for the Delta variant, and they've been quite effective. What about these new drugs we've heard about? So molnupiravir was just approved by the FDA by a very narrow margin, 13 to 10. And based on some early reports, we thought it prevented 89% of infected people from entering the hospital. Well, after some pooled data analysis, that efficacy rate dropped to 30%. So that's why there was such a narrow vote. The other concern with molnupiravir, which is the Merck drug, is that it can affect the DNA in terms of cell virus replication and may affect DNA in our system. So it kind of acts like a chemotherapeutic agent. And so it is contraindicated, so not advised in anybody who's pregnant or thinking about getting pregnant. So more to follow on molnupiravir. The good news is that if it will be distributed through the states through the normal kind of um, pathway that we've got right now for government procured medications and vaccines and supplies. But the state has, California has said they're planning to release it to pharmacies. And that is good news for us because if to administer any of these two drugs to work, you have to do it between for molnupiravir, the first 1 to 5 days from onset of symptoms, and for the Pfizer drug, Paxlovid, between the first 3 days of onset of symptoms. Well, as you all know, the first day you might just have a runny nose and you think you've got allergies, and by the time we have our test results 24 to 48 hours later, the 3 day window for molnupiravir is gone. However, or for Paxlovid is gone, but molnupiravir is 5 days. Paxlovid, let's talk about that. That is the Pfizer drug. It's combined with the low dose antiviral that we already know about called ritonavir, which is used in HIV patients with a proprietary compound called 732133 or 1332. And preliminary data shows that it is effective and in reducing hospitalization. We need to find out a little bit more, and it is anticipated that Pfizer will submit their data within the next 2 weeks to the FDA for review and approval. So stay tuned for that. If it is approved and then goes through the CDC process, likely we might have some drug on the shelves by January. If somebody's hospitalized, there are some drugs, including remdesivir, tocilizumab, baricitinib, and steroids that are being provided. And the newest kid on the block is something called PrEP, post or pre-exposure prophylaxis, especially for the immune suppressed. This was just FDA approved a couple of days ago. And there's an AstraZeneca product called Evusheld, which is a monoclonal antibody that if people who have had transplants are severely immune suppressed, cancer or undergoing chemotherapy for cancer, you could give them this monoclonal antibody, and it's as if you've given them the vaccine and they've developed an antibody circulating in their system to help protect them from COVID. There are many, many people at least 3 million people who are just in strict lockdown and afraid of even visiting family members. And I think this would really be a benefit to them. We don't know how this will be distributed or administered to people just yet, so stay tuned. Another topic is mixing and matching your vaccines and which one will give you a better immune response. And it looks like mixing the Pfizer or the AstraZeneca or the J&J with the Moderna gives a better immune response. It's okay and permitted by the CDC. We do know that if you've had the mRNA vaccines, doses are recommended, or three Pfizers or two full-strength Modernas and a half-strength boost dose at 6 months or more beyond your second dose. And it was just approved 2 days ago for age over 16. If you've had the J&J vaccine, one more J&J increases your protection, but the J&J is not as easy to come by recently, and so it's okay to get one of these other vaccines as your booster dose. Here's an older slide looking at how our efficacy against symptomatic infection waned with different strains of the variant and doses. So the dashed line is if you've had one dose, here's 2 doses, and we'll soon have 3-dose data. And we noticed that 2 doses helped, but we could see some waning with Delta, and that's why Israel bumped it up to the 3rd dose. But it still held well against hospitalization. Some recent data from Israel, just published last week in the New England Journal, showed that of over 800,000 people, those who received their 3rd dose had a lower odds of death than those who did not get that 3rd boosted dose. So, important information for us to know. So that's why, and this was primarily when Delta was circulating. We have no data on Omicron. So what does it mean to be vaccinated? The variants, COVID still looks like this around us when we are out and about. The primary method of infection is still the same. The variants seem to be a lot easier in transmission and infecting us. Whether that does harm is yet to be seen, but there are people who are vulnerable who we do worry about. The current vaccines with the booster doses are likely to decrease our risk of death, but we will still be at risk for some symptomatic mild, as my son calls it, the Omicron-COVID. And that means that we can easily pass it on to loved ones who have a lower immune system or might be fighting cancer. So we should be careful. And but the vaccines will likely protect us from hospitalization, we hope. I am concerned because some data out of Europe does show a rising trend for hospitalizations. We don't know what percent of that is under immunized, boosted, Omicron, or Delta. So time will tell. The next few weeks, I think we'll have some more information. Until we know more, let's just use our common sense. This hasn't changed from last year's recommendations. Just if you can wear your mask when you are in crowds and don't know folks, stay apart if people are unmasked, avoid theaters or large congregate settings, and just, good hand hygiene, because remember, this is also cold and flu season and kids are in school. We're seeing lots of RSV and other viruses. Influenza is starting to take off. So these will help prevent all of the other viruses for you too. Can we travel? This is a common question I've been receiving this week. If you do go overseas, travel requirements have changed. We do still require, the US requires a proof of a negative COVID test or proof of recovery for all passengers arriving in the US, even if you're a US citizen. Now they're going to change that from 72 hours to within 24 hours of arrival. So, folks, I don't know how that's going to work when we've got date changes. So I'm sure we're going to hear more about that since that policy just went in effect last week. What is my recommendation? If you do travel, we do know how to protect ourselves from COVID. We wear an N95 and a face shield, and that's how we manage our own patients in the hospital setting or with COVID. So we do know that you will be protected. However, if you take your shield off or your mask off to eat or drink and somebody coughs around you, then you are placing yourself at risk. We do know that people do get on planes with COVID or they might be minimally affected, test negative, and land positive. In the US, domestic travelers don't need proof of vaccination or a negative test to travel. And I can tell you that I know that people have inadvertently traveled with COVID. They didn't think they felt fine, but by the time they landed, they were felt sick, got tested the next day, and were positive. So there is risk, and also people with colds and flus are traveling. So just keep that in mind as you contemplate visiting family members. The Delta strain is still the predominant variant circulating. It may be a good idea to pre-test yourself, test yourself on arrival. Maybe if you're visiting a grandparent or loved one who is immune suppressed, you might want to isolate yourself for a couple days and then test again and make sure you're a true negative before visiting family members. Avoid large crowds or theaters where you don't know the vaccination status of those surrounding you. I also recommend paper masks instead of cloth masks. Do please enjoy small gatherings indoors if all of you are vaccinated and you know everyone. So, with that, I thank you for your time. I wish you a very happy holiday season. Um, my colleagues in Minnesota and Michigan are experiencing some surge. Teams are flying out from all over to help out hospitals in the Northeast. So, wanted to share with you something that was just published by myself and my colleagues on the Task Force for Mass Critical Care, and to try to help with some of the situations we're facing, especially with staffing strategies, because the healthcare workforce is fatigued. And so anything we can do to prevent even one case of COVID will have huge implications for our healthcare system, which is really on the verge and the tipping point of burnout. But I know that you all are doing the right thing by watching this and have received your vaccines. So I wish you a very happy holiday season and thank you for your attention and your time.